I'm going to go through the medical management following deep venous interventions. All right, here's some disclosures and acknowledgements. So the approach to antithrombotic therapy post-intervention is really something to think about with all these patients that we just reviewed, all their different cases and the different types of devices. So you really want to think about what are the patient presentation and what kind of procedures were done. What different devices did you use? Did the patient show up as an acute DVT? Did you perform thrombolysis or thrombectomy? What type of device did you use? Because that can affect some of the inflammatory changes on the wall. Is the patient a post-thrombotic syndrome patient or is it a NIVL patient? You also want to know about their underlying thrombophilia or malignancy because that can change how you're going to treat these patients. And then you're also going to want to know their risk of recurrent thrombosis. So other things I think about is, was a stent or stents placed? Where are the location of the stents? What's the extent of it? Is just a common iliac vein stent, or do you have an iliocable reconstruction with like 5 different stents in place? And what is the pre and post procedural anatomy? Again, Ron mentioned earlier, what's the inflow? And that's key. So is the inflow diseased? Is it stenotic? Have you done something about it? Or is it wide open? Do you have internal iliacs, common femorals, profunda, all going into a common iliac vein stent? So these are kind of things you want to think about. And here's just an ultrasound image showing you a occluded stent here, and then you've got no flow on color Doppler. So the effective procedure that you perform the procedure that you perform can have an effect on the downstream anticoagulation. So CDT alone is limited procedural endothelial damage, but we're not doing that as much, but there's still a role for it. But when you do perform mechanical thrombectomy and or angioplasty, sometimes with rheolytic thrombectomy and all these new different devices, there is endothelial damage that occurs to the wall to some degree. It's increased localized and systemic inflammation that is released due to cytokines and cell surface receptors, and you get exposure of procoagulant tissue factor and other proteins that trigger additional coagulation. So that's what happens when you get any thrombus. But when you're working on the wall of the vein, you're sucking out clot, you're scraping off clot, you're doing something with that clot or ballooning it, you can release additional factors. Again, it's important to notice the anatomy, the inflow, whether there's a presence of a stenosis or occlusion of the inflow vessels will potentially risk increased thrombosis due to disrupted flow or not having inline flow. Again, limited inflow is important. How robust is the available inflow at the end of the intervention? So if you're stenting down to the common femoral vein, is the profunda open? Is the superficial vein open? GSV may be open, all leading into your stents. And if they're not open, how are you going to change your management? And then again, the extent of stenting if performed. Another key important point to think about is the residual thrombus. When it is extensive, it may impede flow and cause recurrent thrombosis. In the ATTRACT subgroup looking at residual thrombus, the iliofemoral group suggested benefit, but there was a lack of association between thrombus clearance and PTS. So all those patients that they looked at in that paper by Razavi et al., there was 88 patients or 87 patients who had a Marder score of 0, and I think Ron mentioned the Marder score earlier. In those patients, there was still a decent number of post-thrombotic syndrome, even if you had a Marder score of 0. So clearing all that clot is not necessarily truly helpful yet, and so I think we're going to get to some more answers here shortly. All right. So there is a general lack of consensus. So we started off the session with Dr. Desai talking about a randomized controlled trial, where there's really not that much randomized controlled data here. And so this is a paper from the European Journal of Vascular and Endovascular Surgery looking at a Delphi study and asking a bunch of venous experts about their different anticoagulation patterns. And you can see that there is a wide variety of this. So this is a standard acute iliofemoral DVT in otherwise young, healthy 30-year-old male. And he had May-Thurner syndrome, got lysis, got stenting, and otherwise did okay. But you can see here that there's a big variety of patient treatments. So low molecular weight and then warfarin for 12 months and about a third, and then a whole variety of different things with DOACs and a combination of antiplatelet agents. So it's really interesting to know that there's really not consensus. When you go into the chronic space, there's even less consensus. So we really don't know what we're doing with this. But this is a patient with chronic PTS that is treated, recanalized, and stented, and there is a huge amount of differences in what people would do. So just briefly, in non-thrombotic lesions, probably the one thing we can predominantly agree on is that these patients, when you look at some studies that were published, again, retrospective, but these patients basically do very, very well at several years out, 4 years out, 5 years out. Some people place patients on clopidogrel for a few weeks or a few days, just depends. But in general, these patients don't need to be on a long-term anticoagulant or antiplatelet agent. When you do, the data that we do have actually is regarding low molecular weight heparin and post-thrombotic syndrome. So these are some studies that were performed in Europe with looking at tinzaparin, which is a cousin of low molecular weight of enoxaparin that we use, and we can see that there is actually a reduction there's a reduction in post-thrombotic syndrome. There's a reduction in rethrombosis, and there's also a reduction in venous reflux and competence of the valves with low molecular weight heparin over Coumadin. So there's actually benefit here. Additionally, specific symptoms of post-thrombotic syndrome. So these are most of these symptoms here on the left side are actually the components of the Villalta scale or the NVCSS, and you can see that they favor the use of tinzaparin or low molecular weight heparin. So just thinking about early thrombosis of venous stents, it's important to know that these patients can be treated with different measures, and again, the different patient populations, but there can still be occlusion. And so these are a review by Dr. Marston and his group of 106 patients with iliofemoral stents. They had varying degrees of inflow stenosis at the end of the case. The patients were all put on anticoagulation, or nearly all, and about half were put on antiplatelet agents. And if you look at these patients, there was a stent occlusion that occurred within 3 months in about a quarter of the patients. And what they did find, however, that was significant in this paper was that treatment with low molecular weight heparin for greater than 10 days was associated with significantly lower odds of reocclusion. You can see the primary patency on this graph here, the figure that low molecular weight heparin greater than 10 days had highest patency, followed by warfarin, and then followed by factor Xa inhibitors. So what is the role of antiplatelet agents in addition to anticoagulants? Well, again, there is not consensus on this, but there is some initial data. Initially, post-stenting, this is used by many operators, I think, especially in the post-thrombotic patients. And that's usually due to lack of stent endothelialization and a risk for rethrombosis there. Again, there's inflammatory states involved here, so acute thrombosis, and it can be increased by what devices you use. And then chronic stenosis, as we know in the normal system, venous system is a low flow, low shear state. There's good blood flow going through, but when you do get this collagenized venous endothelium, it gets thickened, scarred, and it causes actually increased shear forces. And we've seen this on MR, we've seen this on ultrasound and other images, and that causes increased risk of platelet-rich thrombi. And so therefore, it may be helpful to have antiplatelet agents. There were some studies that looked at looking at post-thrombotic syndrome, and there was a torpedo study which did find that patients who were on aspirin did better, although it wasn't a large proportion of these patients. I think this is a paper written by Dr. Desai here, retrospective review of 87 patients with vena cava or iliofemoral venous stenting. Maybe that's the other one, actually. And in these patients, what you can see, the triple therapy, anticoagulation plus aspirin and clopidogrel, reduce the odds of in-stent restenosis and stent thrombosis compared to those patients on dual antiplatelet therapy. So there is some benefit, but I would also notice that there's increased bleeding. And so we see this in our practice as well. We do this frequently for patients that are getting iliocaval reconstruction for chronic occlusions, and we do put them on dual antiplatelet therapy with an anticoagulant. Here's another study looking at a retrospective review of 62 patients with iliocaval stenting, and note that greater than 50% of these patients had recurrent DVT, and 97% of these patients were treated with anticoagulation with either warfarin, enoxaparin, or a factor Xa inhibitor, and many of them received an antiplatelet therapy as well. Primary and secondary patency rates at 1 year were 70 and 92%. That 70% is very consistent with other published data, but what you can see on the Kaplan-Meier curve on the right there is that antiplatelet agents, patients treated with antiplatelet agents had significantly higher adjusted primary stent patency compared to those not on an antiplatelet agent. And it decreased the risk of stent malfunction or thrombosis at follow-up, as well as it remained the only statistically significant factor. So I'll just briefly mention the concept of immunothrombosis with stasis, endothelial cell injury, and hypercoagulable state, but inflammation plays a significant role and is important in these patients. So inflammation in post-thrombotic syndrome is regulated by cell surface receptors, cytokines, and they can cause thrombus formation, organization, and vein recanalization in the chronic phase, as you can see here, and these change over time. So some of the things that can be used to treat inflammation include statins. Statins have an anti-inflammatory effect, as we know in the arterial literature. They reduce inflammatory markers and neutrophil and macrophage infiltration. And I'll just skip to the bottom point where a study that had 234 patients randomized to low molecular weight heparin, as well as low molecular weight heparin and rosuvastatin, actually had an improvement in their with lower levels of CRP, which is an inflammatory marker, and they had an improvement in their Villalta score and a decrease in incidence of PTS in the group that had statins. So in conclusion, the medical management post-intervention varies significantly among operators. If we all ask the question, like that Delphi consensus statement in this room, I'm sure we'd get about 12 different answers. Low molecular weight heparin, however, has shown an anti-inflammatory and anticoagulant effect and reduces post-thrombotic syndrome in a randomized trial. Antiplatelet agents may reduce in-stent stenosis and rethrombosis. Again, these were all retrospective reviews, but they are fairly useful and they do show a benefit. There's a myriad of factors involved with maintaining patency, again, including inflammation, so consider that in treating your patients. And again, lack of consensus. And just plug the C-track trial. Thank you.